name's James Turvill. I'm just a simple clinician. Okay. If you like what you see, then believe it. If you don't, just call it prejudice. Okay. I don't mind it. I met you at March, and that essentialism, consequentialism slide is fantastic. And I want to try to pick that up at the end. The other thing I need to let you know is that I've not met Ramesh before, James Turvill, and he may say something completely different. Okay, so and believe him. What else am I going to say? So this is based on some research we've been doing at York, and it's largely looking at how we handle patients fulfilling NICE NG12. That is not those, these are high-risk patients for colorectal cancer, not low-risk patients for colorectal cancer. So not DG30 so much, although there's a little bit about that maybe, and a little bit about screening maybe as well. And one sort of philosophical message I'm trying to get through is I'm not keen on the idea of a test to rule out cancer. We use fecal calprotectin to rule out IBD, but no one's going to come to any great harm with that. What I think we're trying to do with FIT is to find the cancer quickly. NG12 was set up originally accepting that you would unnecessarily investigate 97% of patients to find those 3% with cancer. So NICE is all about finding people who might have cancer, and we need to use FIT to drag them in, not to keep them away. And that's important because FIT of itself does miss cancer. Oh dear me. So how do I just
click on the button to do it.
The same one?
That's it. Yeah.
I'm so sorry. Worse than you. So I'm going to talk about a study we've been doing. This is a diagnostic accuracy study, and what we do is we've been taking 700 patients. This is unpublished, I'm sorry to say. We presented some of it in part before, but no one else has seen this, so that it's new to you, it's brand new. We looked at 700 patients, and they were all referred from primary care with symptoms fitting NG12. And we think this is as good as we can get what's going on within primary care. What we really want to know is what the GPs are doing, but because GPs have to respond to NG12 in a very fixed way, there's very little discretion. So we think what we're seeing here, this population, is what GPs are seeing. So they have all the symptoms of NG12, but we didn't bring in FOB, so no one's had an FOB. And what we've done with these patients is work them up conventionally without knowing what any tests are doing. We've done two FITs and 2 fecal calprotectins. That's one test each on 2 stool samples done prior to investigation. So our assumption is that the illness that prompted the referral is the same in those two tests. And what we're trying to do is to see whether tests on both or tests on one improve either the sensitivity or the specificity of these assays for patient benefit. And we have tested the FIT using some kit that Bullman very kindly provided for us, loaned to us, and we used a Bullman FC, the fecal calprotectin assay. So clinicians don't know what's going on, and the median age of these patients is around 70. So they're referred urgently. They're all suspected colorectal cancer. They have 2 tests beforehand, and we're trying to see whether we can improve diagnostic accuracy by correcting for unknown analytic or pre-analytic errors. Full stop. So that's the test, and going back to the title, we've got to decide from that study what we mean by FIT negative, and I'm going to define what I mean by fit negative first, and then we'll see what we do next. So from this study, I'm putting to you that we've got 1,000 patients, and this is the clinical conundrum that needs to be dealt with. And this isn't necessarily the clinical conundrum that is talked about in some of the papers that are published, but this is, I think, real life. These are the patients that are presenting to primary care with colorectal symptoms, and we need to find the cancer. And approximately 2/3 of these patients will have functional disorders. I call it IBS. But this also includes benign anal canal bleeding, and it also includes iron deficiency anemia where no cause is found. This is the group that are currently being investigated and that are costing the state vast amounts of money, and we need to cleave those patients aside. Then we have 4% of patients who have colorectal cancer, and then we have 4% of patients who have significant polyps. These are polyps larger than a centimetre in size, and they will all become cancers. And then we've got a difficult group here that I've called organic enteric disease, and this is defined differently by different authors, different studies. But for me, these are patients who need secondary care intervention. So these are patients who have organic structural disease, and they need to be seen in secondary care for that disease to be defined and so managed. It includes a lot of patients with inflammatory bowel disease or microscopic colitis, but also diverticulitis and a range of others. Then there's a group here who have diminutive polyps, polyps less than a centimetre, and probably nothing's going to come of these patients because they're 70 and they'll go to heaven with their polyps. And we probably don't need to worry about them, but if it was me, youthful and young, I'd want to know about this. And then there's this really tricky group here, which is also about 4%, that I've called other. And this is non-enteric disease that is being picked up through the colorectal pathway. And in here, you've got other cancers. So you've got pancreatic cancer, you've got lymphoma, sarcoma, ovarian cancer, renal cell cancer, lung cancer. So, and FIT's not going to do diddly-squat for these patients, you see. And so 40% of all of the cancers that the GP refers will be non-colorectal. And we'll come back to this in a minute, but that's the consequentialism. FIT, in my view, the way FIT's going to work or be successful doesn't turn on how wonderful it is at diagnosing colorectal cancer. It will be on how we untangle this cohort from that cohort. Okay so far? So that's the population we're dealing with. That's, I think, the real world. And what we're just at the moment doing is, we haven't started the talk yet, we're just defining what we mean by fit negative. And the two pie charts at the bottom are what happens if we use a detectable fit as our cutoff. And if we use detectable fit in our cutoff, we get 290 positive fits and 710 negative fits. And these pie charts are, I presented the data differently from up here. This is the totality of diagnoses. This is the proportionality for each colour of disease. So you can see that we pick up almost all, but not all, of the colorectal cancer with detectable fit. I recognise that this is our data and is different from Mauer's, but we have missed. I'm reconciled to the fact that whatever the cutoff is, we will miss colorectal cancer, but not much. What's great is that, and then so this is the irritable bowel syndrome. So most patients are spared investigation. Diminutive polyps behave like irritable bowel. We identify half of our organic enteric disease. We detect half of our other disease, and we detect half of our significant polyps. So fit's fantastic, but not perfect. So that's detectable fit. This is the same chart if we use a cutoff for greater than equal to 10. That's what DG30 recommend. And we see, in my view, a similar proportionality of cancer detections, but we reduced the total number of patients from 290 to 140. And to me, that's a big win. So you're sparing initially 860 investigations, and if you go to fit greater than 30, you get an even smaller number, but you begin to miss more cancers. Okay. So we can plot a ROC curve, and we get error under the curve of 0.9 for an optimum cutoff of 12. Okay. So starting the talk now, 12 is 10, I'm going to call it 10. So, because I'm a clinician, I don't know what numbers mean. So fit negative follow-up, the patients had 1 fit and it's come back at less than 10, and then what you do, okay? So that's why I'm starting the talk effectively. But that's the reason why I've chosen that, because with our data, 10 is gives us the best sense and spec, and no other number can detect all cancer, which of course trumped it. So we're getting the best way of detecting cancer most efficiently if we set it at 10. So this is now the cohort we've got left. We've taken 140, 150 patients out of that 1,000, and we've got 850 patients left who have not been referred. And how do we handle that cohort? We've still got a little bit of cancer here, 1% of cancers. And we've still got a lot of polyps, 3%. 3% of these important diseases with cancer in, a significant amount of organic enteric disease, but we've got 70% is functional. And so the fit has been fantastic, but how do we move that forward? And I'll just show you what this looks like. So we will have, in 850 patients, we'll have 6 cancers, we'll have 23 significant polyps, most of which are chance findings, so they're not symptomatic. And then this is a sort of organic disease that we see clinically, that our clinicians deal with and manage. So we do see 40% is IBD and microscopic colitis, but I've included a lot of diverticular disease because these are elderly patients and they are symptomatic from it. And then radiation proctopathy is the next big problem, the big symptomatic burden. A lot of people have radiotherapy nowadays. And then we've got non-enteric disease, which is a big concern to me, and there's another 24 cancers there waiting to be diagnosed. So we've missed a lot of cancers. As I said, these are lymphomas, sarcomas, ovarian cancer, and then our functional diseases. So what can we do? We're fit negative, and how can we get better? Well, NICE NG12 is all about finding that needle in the haystack. It's all about finding that cancer. So let's just sort all that for a minute and just see how we can find that cancer. And this is, I hope it's clear to you, this is sensitivity and specificity, but perhaps what's more important is the negative and positive predictive value. And this first 3 rows is if a single sample is performed. The second, if we look for 1 positive in 2 samples of fit. And the third group is if we add fit and fecal calprotectin. But we're saying from our ROC curve that fit at greater than 10 gives us the best sense and spec. 0.82 and 0.88, negative predictive value of 99%, PPV of 27%. So that's much, much better than what's currently happening without FIT. But if you repeat FIT and you're just looking for cancer, and you're looking for just one of those two to be positive, so this is why it's become a rule-in test rather than a rule-out test, because if it's rule-out, I think you'd want them both to be positive. Well, we don't make, with the data we have, we don't see a significant shift. You can make the case that we've marginally increased the sense and spec. If you increase cut-off to about 30 and repeat it and just look for it once, but this isn't significant with the sorts of numbers we've got. It's still not doing what we want, that is diagnosing all cancers, and the positive predictive value isn't significantly different. So with the data I've got, I'm not convinced that adding in a second sample for these high-risk patients is able to identify this patient. If you do a ROC curve for those two, you can improve the area under the curve to 0.92 from 0.90, but our numbers are too small, that's not significant. And you can increase the positivity threshold to 43, and for my purposes, that's where the 30 is here. So, yes, maybe there's some place for this, but at the moment I don't think the evidence supports it. Using two FITs might prove really useful in the bowel cancer screening program, because a marginal increase in the sense and spec from 0.7 or 0.82 to 0.86, if you're dealing with population screening, that can save a lot of money, But for the symptomatic patient, I'm not sure that it makes very much difference. And in repeating a test, you've got additional costs, you've got additional time, and you've got compliance problems. Patients aren't going to do it, and then, so I'm unconvinced that this possible benefit in providing a second test is offset in clinical terms from just cutting to the chase and the one FIT. Do you see what I'm saying? Is that okay? Fecal calprotectin, adding in fecal calprotectin is a disaster, isn't it? We all know that. It will pick up some cancers. So some cancers are behaving differently, and I just need to make that point. What's impressed me is we're talking about there are very few cancers being missed, but in this study where we've done two FITs around the same time prior to investigation, it is the cancer that's not lighting up, not the assay. So the cancer's behaving differently. The cancer is not bleeding. Okay, it's not bleeding once, it's not bleeding a second time. So it's not the assay, it's that a small number of cancers just don't quite behave the right way. Okay, and I think we've just got to accept that. So if you add in fecal calprotectin just looking for cancer, you do pick up the odd extra one, but your positive predictive value is a disaster. You end up testing everyone, it's pointless. Okay, so if we're just looking for cancer, if we're just focusing on cancer, I see no point in doing anything other than a FIT at 10. You can, for symptomatic patients, I don't get the case for repeating it because we're still going to miss the cancer and you're going to waste time and money and lose compliance. So is there another reason for doing another test? Is there an advantage, not for the cancer, but can we pick up more of these important polyps? That's really important. Can we pick up this organic enteric disease, or can we pick up this this disease which has other cancers in it that might otherwise fall into some other pathway? So is there an advantage in doing something different to pick these up? Okay, and So we've looked at a number of scenarios. The first was to, and so we're going to go back to these pie charts and I'll talk you through them. So this is the pie chart of the 850 now patients who were initially fit negative, and what if you repeat the fit? Okay? Well, you identify 50 patients, you pick up a little bit of cancer, we've said all this before, and you pick up a little bit of organic enteric disease and half of the polyps and not much of the other disease, what you'd expect that. So it's not great, it's not compelling. And if you present this data in table form, so this is all organic disease, cancer, polyps, and organic enteric disease. Repeating the test and increasing to the cutoff of 30 doesn't really alter very much. Sensitivity doesn't change very much, specificity doesn't change. So I don't see any benefit in repeating the fit to pick up non-cancer. Okay? Once more, if you add in fecal calprotectin to the fit, all you do is generate large numbers of false positives. So here we're talking about an extra 50 patients for some yield. Here you add in fecal calprotectin and suddenly 470 plus 150 of your 1,000 patients are positives. And any of the savings that you're looking to achieve in using FIT are gone by investigating all of this functional disease. You will pick up the organic enteric disease, and you'll pick up more other disease, but I don't find it compelling. If you do a FIT and a fecal calprotectin, it's equally bad, because the fecal calprotectin just generates too many false positives. Okay? The other way to think about this is to manipulate the symptoms and see whether we can add in a symptom cohort to a FIT to improve the detection of cancer and these other symptoms. And a number of groups are doing that. So Nottingham takes out rectal bleeding from its FIT pathway. But for me, again, I'm afraid I find this not compelling. If we add rectal bleeding to a single FIT, 30% of the patients will have rectal bleeding. So immediately you're having to investigate all of these patients. I think the reason behind it was because some of the studies, and Ramesh, I think your study showed a lot of the missed cancers were rectal cancers, and so you would pick that up with the FIT. But in our study, we're seeing cancers in the sigmoid and the cecum as well as in the rectum. So I think that rectal bleeding, all that's doing is generating more false positives, and I don't think it's compelling. We've got to, if we're going to get the maximum out of FIT, we need to recognise that it's not perfect, but it's really, really good. But it's really, really good because it's both very sensitive and it's efficient. It saves us having to investigate huge numbers. And if we use other symptoms, abdominal pain, weight loss, change of bowel habit, it's the same. We don't get any benefit, but I've just showed you rectal bleeding. Okay, so just to sum up, make sure I remembered everything I had to say. The FIT will pick up almost all of the cancers, but not all of them. You have to remember that. People out there think it's a no-brainer, and their brains are disengaged about this. But if we're to make it work for us, we have to keep it its efficiency, if that's the right term. So if adding another fit isn't going to work for the symptomatic, and fiddling with symptoms isn't going to work, then we rely on the residual patients, these 850 of the 1,000, being treated, being managed, and seeing what drops down the other side. Okay? Now, what's happening at the moment with NG12 is that GPs aren't allowed to apply any discretion. So any symptoms, and they're referred. In the past, symptoms could be managed expectantly, and many of those symptoms will settle spontaneously, but that's not allowed. So the hope is that in this cohort of negative fit patients, they be managed as if they're likely to have a functional disease, and we see what settles at the bottom. We would infer that those with cancer will remain symptomatic, and so they would be referred on. Those with polyps, that's more difficult. Some will be symptomatic, some won't. All of those with organic enteric disease and all of those with non-enteric cancer will remain symptomatic. And hopefully these won't be. And the thing about referring symptomatic patients, though, is that you have to review them first. And Sally touched on this. Who's going to review these patients? And so, to my mind, this slide epitomizes the essentialism, consequentialism bit of fit. The essentialism bit is that we know it's wonderful and it's going to detect almost all of the cancers, but the consequentialism bit is how this cohort of patients and this cohort of patients are managed in this fit negative group. If they're managed badly, they're all going to get referred anyway, and it's going to cost vast amounts of money, and it's all going to be rather pointless. Do you see what I'm saying, or am I? Yeah. So, for someone to remain symptomatic, there's a gap here. They have to be reviewed, and who reviews and what's done with the review is going to be key to how effective fit is in clinical practice. So, when the fit is negative, when to refer and for what are key. Okay? And Sally again touched on it. The first question is, who is going to refer these patients? Who's going to review these patients? Are these patients going to be reviewed by primary care or by secondary care? Primary care are gatekeepers. They're good at waiting and holding if you encourage them to do so, although they carry a risk for that. Secondary care are useless at gatekeeping. What they do is investigate. Secondary care, they investigate. They just make sure there isn't cancer there. So if primary care do not review, all these patients are going to be investigated anyway, and there'll be no money to be saved. So if primary care do review these patients, then what? What are the options? And I think there are these options. The first is that GPs will treat patients symptomatically and then follow them up. And the difficulty for GPs is that theirs will be the risk. Presumably, if they treat all symptomatically and follow all up, they will then refer urgently those who are still symptomatic, and maybe even at that time, because that'll be 4 or 6 weeks down the line, they may repeat the fit. And it may be that a repeat fit over that sort of timeline will pick up that patient or those patients. So this is what I hope will happen. But an alternative is that this will happen. That is, that the GP will treat patients symptomatically, but will refer all of them at the same time. And the issue then will be with what urgency. And And the only benefit to secondary care will be that it may be a routine referral. And this model is happening in England at the moment, and secondary care is making the decision. But this is messy and inefficient in my opinion, and leaves the door open to many of these being unnecessarily investigated. Or the GP will treat symptomatically all of the patients but refer some, so be allowed some discretion. But what degree of discretion is allowed? Will the GP be allowed to ignore the fit and refer anyway? They still have clinical suspicion, they're still unsettled that they have GI disease, and they may of course be right. So will they be allowed to refer anyway? Or what about non-GI disease? How can they refer? Can they just say, no, okay, I accept the fit is negative, this patient's very unlikely to get colorectal cancer, but I'm still worried about them. Do they have non-GI disease? That is, this group. And what we don't know is how many GPs will have that concern. And so, for all we know, all of these patients will be referred because the GP is concerned about this cohort and how to identify that cohort. These patients, we've looked at their symptoms, they're exactly the same as these symptoms and these symptoms and these symptoms. We can't untangle these patients. Or again, will the GP repeat the fit down the line? And then the next question is, will the GP be allowed to initiate investigations? Will the GP be allowed to initiate CT scanning or flexible sigmoidoscopy? I think what's going to happen is that we are going to see a lot fewer colonoscopies, but we're going to see a lot more CTs. And I think GPs will be requesting CTs up to European numbers, effectively to untangle this cohort. And I think that's the consequentialism of FIT. So FIT negative, don't repeat it, I don't think. It's very good, it's as good as it's going to be. The difficulty is what comes downstream. So I've drawn up this pathway that's more complicated, irritatingly, than this pathway that I hadn't seen before, which I think is very good. But I want you to look at my pathway because I invented it, and compare it with this. And I think something like this will emerge, but who knows, I don't know. So patients will have intestinal symptoms, and it's clear that there are some groups that will need a separate pathway. So if you've got a mass in your rectum, that's going to need a separate pathway, and iron deficiency is going to need a separate pathway because you need to, not least because you need to do a gastroscopy. So they will find that out quite quickly and sort that out. We know the specificity of FIT falls as you get younger, and that's because the point prevalence of disease changes, the type of disease changes, and of course that's why the FAST test is so attractive. They recognise that age is important. So we have to stick in some sort of age cut-off, and I've just put 50 because I think that's what it'll be. But it might be 40 or 60. And then you'll have those who are 50, all over 50, they'll just have a FIT. And the FIT will be positive, and they'll go 2-week wait for either an outpatient or colon. That's easy. And so what I'm saying is everyone will have a FIT. Okay, this is not just DG30, this is everyone. You don't worry about symptoms. Symptoms are useless, they're non-specific, as Sally was saying. Why fiddle with symptoms? Age is better. So if the GP is concerned, you'll just and they're old enough to have cancer, you'll just do a FIT, I think. If the FIT is negative, then you either are still worried as a GP and you refer urgently, and you may or may not request a CT scan at the same time. But you've got to be allowed, the GP has got to be allowed to, we've got to recognise that the FIT negative will miss cancer, and particularly other cancers. And so the GP is going to have to be allowed to say, well, I don't believe that, and I'm still anxious about cancer. And that pathway, how big that is what's going to determine the success of this rollout. The rest, if the GP is not concerned, are treated symptomatically. What we're desperate for is the majority to get better and disappear here. And we don't know how many of those patients are going to do that. If they remain symptomatic, they've been FIT negative, then what do we do? Well, if they're less than 60, maybe then you can add a fecal calprotectin. We'll talk about fecal calprotectin this afternoon. And in this context, you've already taken the cancer out largely. Fecal calprotectin may still have a role. If they're over 60, then what do we do? Either routine outpatient, or does the GP initiate a flexible sigmoidoscopy? Because that's where some evidence suggests most FIT negative cancer is, or a CT scan. I think something like that will happen. If we go back up to the top, if the patient is less than 50, the GP still has to be able to still then has to decide whether he or she is anxious about the patient. And if he or she is anxious, then the patient needs a FIT. But if the symptoms are not suspicious, and GPs are good at assessing this, then they can go into a fecal calprotectin pathway. And I think something like this is what's going to emerge. So we've got 1,000 patients over 50. You'll have another 1,000 under 50. But of those 1,000 over 50, if we set the cutoff at 10, 15% will be FIT positive, and we'll pick up 90% of the cancer. That's easy. 85 will be FIT negative. The GP is going to, of those 85%, what do we think? What do we guess? It's all about how this and this cohort are interpreted. My feeling is of that 85%, 50% will get better spontaneously. These are patients who have not had an opportunity to be treated symptomatically before their referral, and I think 50% will get better, and that's 42.5% of the 1,000. And then I think 30% the GP will still be worried about, and so they will get referred. And I think 20% the patients will remain symptomatic after being treated, and they will still be referred. So hopefully, and this is purely conjecture, but hopefully we will spare, by using FIT, we will spare referral of 40% of patients, 40% of 1,000. That's my hope. If you model crudely and just apply FIT at a cutoff of 10 and add in symptom resolution 10, 25 or 50%, your positive predictive value is much better than what is currently happening. And so even a modest symptom resolution, I think, will be financially cost effective. I need to thank the charity that funded me and Alpha for providing some really useful kit. And that's me done. Thank you very much.
No, that's okay. So I'll open up to the audience. Can you state your name and where you're from, please?
Sir.
So, Andy Marston, consultant gastroenterologist at Hereford.
Hello.
Hi. Correct often.
Do you agree with it?
Yes, I do. I think the nice TMG guidance is quite important, actually. You look at that one table that's implied at 1,000 patients, you miss no cancers. It's incredibly misleading. And it sets you down a route of confidence that's not real.
And the GPs believe that it's completely, that it's 100% effective.
Yes, and that's what I'm thinking of as well. We're working now to launch an pathway there soon. There are so many gaps in terms of reassurance that it's more than it. Although, as I used it in my practice, there's an awful lot of patients I see, now patients, who are 62, changing about it, and it's subtle, very subtle, and you end up scoping them because you feel you have to. And in my hands, I think that kind of test may be quite good, but I think in primary care, the risks are very high.
We'll talk a little bit about this this afternoon, but so we use fecal calprotectin a lot, and we estimate that for every one patient historically referred, this is for low risk, 2.5 were coming along and being managed successfully, and that we never know about. And so if you've got 2.5 extra patients being tested, and the false positivity is anything other than small, you're in difficulty. I should say that we didn't use the picker device in our study. We did because we were providing two stool samples, and the patients were being sent out a letter, and they brought a stool sample with them to the clinic, and then the lab dipped them. But we ran a separate cohort of the final 150 patients with an additional picker as well, and it's the sense and spec is the same. So I don't think it's because of the degradation. I just think in this cohort of elderly fast-track patients, you will miss cancer, but not very much at all, and it's a wonderful test.
Please.
James, thank you very much for that. It was very interesting, and it's really set the scene very nicely. I was just curious, I was very supportive of your two-step negative concept. With regards to your data on that, I was curious to find that if a cohort had one fit negative and a second one was positive, granted you picked up a few more cancers. However, I did notice there was a few more of your IBS functional group in that as well.
Yes.
How do you explain that?
Yes. So, and so the effect was that you're and that are you gaining anything from that small additional increment of cancer for bringing in that extra baggage? And I think it's just that these are, a fifth of these patients are either on non-steroidal, apixaban, clopidogrel, warfarin, aspirin. This is the problem. We gastroenterologists pontificate about this. It's the poor old colorectal surgeons who don't know what these names mean, who are investigating these patients, and they've all got more comorbidity. And so I think you're just, and that's why the fecal calprotectin is even worse, because they're all just oozing a little bit of something from their worn-out elderly bowel. And I think that's the only thing I can suggest.
Thank you very much.
Thank you. See you later.